Good morning, welcome everyone. My name is Ramesh Kolluru. I'm Vice President for Research and Economic Development at the University of Louisiana at Lafayette. So for those of you that are from out of town, welcome to Lafayette, the University of Louisiana and the Light Center. And I'm pleased to invite you to the Cajun Code Fest. Now in its 6th year, it is bigger and better than ever. The number of RSVPs we have is including the coders and participants for the summit and the roundtable today are at 400, and I was freaking out because we had no idea how to manage with the budget that we have. But thanks to the budget cuts that higher education has had for the past decade or so, we've kind of gotten good at stretching the dollar. So we have stretched the dollar to its maximum today. But thank you for being here, and thank you each for being part of this event. And I want to take a moment to thank our sponsors, the summit sponsors, CGI, Lafayette General Health, and LHC Group. The summit co-sponsor, Oceans Healthcare, and the Cajun Code Fest sponsors, including Oak Ridge Associated Universities, Blue Cross Blue Shield of Louisiana, Acadian Companies, One Acadiana, and LEADA. Without their generous support, we wouldn't be able to convene this distinguished gathering with one shared purpose. And that purpose is to address the opioid epidemic. While UL is a major research university, and as researchers, we think we know all the answers, and we have significant intellectual capacity at the university, addressing a crisis of this magnitude will require us to go into these kinds of conversations with the knowledge that you don't know all the right answers, with the humility that you might not even know the right questions to ask, and with the clarity that you will need collaborations. And that's the reason why we sought to partner with the US Department of Health and Human Services as part of their first hackathon on opioid epidemic in December of 2017 in Washington, DC, and continue to partner with them to be informed by what's working at the national level and what's not working. And as such, so I want to thank you, Bruce and Mona, for your continued partnership and collaboration, and for allowing us to become the nation's first franchisee of the HHS Opioid Hackathon. That was quite a thrill. And that's why we are also partnering with the Louisiana Department of Health to see how we might assist our visionary secretary, Rebekah, and her team in Louisiana's efforts, not just to contain the opioid epidemic, but as appropriate, to prevent the loss of human life and to contain the unfortunate loss of life that we have seen far too often. And that's also the reason why we are partnering with USDA Rural Health in hosting this summit, because the opioid epidemic is now a major rural public health crisis. So thank you, Carrie, and the team for USDA for your partnership. And finally, I want to tell you that we want to partner with all of you in this room. It will take collaborations with healthcare leaders that are assembled here today, with policy makers that are here, with social workers, with community developers, with inventors and entrepreneurs and innovators, including some of these high school children that we have assembled here. And all of us need to pull in the same direction in order for us to lead this transformation. And with that, I want to thank each of you and wish you a great day, and invite the panel, Dr. Carrie Castille, Dr. David Callecod, wink wink. Senator Cassidy is on his way, and Secretary Rebekah to the panel. And I'll kick off with an introduction of Dr. Carrie Castille, who is the State Director of the US Department of Rural Development in Louisiana. She is a nationally recognized leader on water issues and a Food Systems Leadership Institute Fellow, and was appointed as the chair of the USDA National Agriculture Research Extension and Economics Board. That's quite a lot, and you can see that on her CV. But what I want to tell you is that Carrie is one of the most passionate and capable people that I know, and we are very proud to call her our alumna and an inductee into our College of Engineering's Hall of Fame and the Wall of Honors. She serves currently in the role of the State Director of USDA. With that, Carrie, over to you. You can do wherever and what way.
So wow, what a great crowd. Good morning, first and foremost, and thank you for everybody being here. I do want, where's our hackers, our coders? Can I get a hand? Come on, a little bit more. All right, now we need to give them a big round of applause. So this morning, my goal is to see if I can give you information to be able to help you on your task and on your charge to be able to help identify potential solutions to address the opioid epidemic. So you might ask, what does rural development, USDA rural development, have to do with the opioid crisis? Well, number one, I will tell you that for our rural communities that are already struggling to attract new businesses or maintain existing employees, the impact of the quality of life and economic prosperity can be absolutely enormous, especially for our rural communities. USDA rural development, what we do is our goal is to be able to build or sustain our rural communities. We like to say we can build a town from the ground. But from my perspective, and coming from Louisiana, being an alumni of this great institution, it's my opinion that if we have anybody that leaves our rural communities for any reason outside of economic prosperity, we're not doing our job. So we need to make sure that we're doing everything we possibly can, put mechanisms in place, build our rural communities, and sustain rural economies to make sure that the crisis doesn't get worse. Because in my opinion, it's symptomatic of economic conditions. So I will tell you the administration has declared the opioid epidemic as a national health emergency. I want to emphasize a national health emergency. I don't think that there's one state in the U.S. that's not impacted in some way, shape, or form by substance use disorders. And I think it's a testament to UL and our partnerships here, just to have the people that we have, to be able to attract the panels that we have, and knowing that our senators and our congressmen have taken time out of their busy schedules to be here. It speaks volumes. So for our hackers and for our interested parties, I want to let you know a couple of statistics based on research that we have from USDA. So jobs in rural America tend to have higher injury rates as they depend on physical labor and involve more risk. Jobs such as manufacturing, mining, and farming. When workers are injured, a doctor may turn to painkillers more quickly because physical therapy or other alternatives are not readily available as they are in an urban center. The rural population, on average, is older, with a higher incidence of chronic medical conditions. Lastly, many rural areas are geographically isolated, with lack of access to treatment services, recovery support infrastructure, or mental and behavioral health professionals. And I want to tell you that's our job at USDA Rural Development, to make sure that we're putting in place the mechanisms, again, recovery support infrastructure, mental and behavioral health professionals, innovation, infrastructure, and partnership. So that's what we do. So what do we do at USDA? Again, we help to build communities. We help to build towns from the ground. But I want to tell you that we're working with our stakeholders and our communities to help deal with the crisis, because we know that we can identify effective solutions. And it's all going to begin here. USDA recently created an innovation center. And a critical component of our innovation center, which is the National Innovation Center housed in Washington, D.C., with the advice and input from all states, is to be able to use this innovation center as a way to be able to strategize and, again, take what we've learned and bring those back to Washington, D.C. So here's your charge, hackers. So I want to encourage you to engage with us, your federal, state, and local representatives while you're here, and you have a plethora of expertise as well as information available to you. The other thing that I would do is encourage you to look at relationships. How do we build relationships? How do we partner? Because there is no one who can do this alone. No one agency, no one effort that can do this by itself. So I would encourage you to look at partnerships. The other thing that I would do is encourage you to stay informed. This is an ever-changing topic. You're going to continue to see technology that's going to advance. You're going to hear speakers that are going to talk about prevention and recovery and treatment. Ask questions. Let us know if there's anything that we can do to be able to help you. And again, when you start thinking about hacking, I ask you to consider the impact on the rural communities and what the impact has on our economy, ultimately, in our state. So thank you.
Thank you, Carrie. Appreciate it. And I hope the students were taking, or the participants and the hackers were taking notes. Next, I would like to invite a good friend and a colleague and a sponsor of today's event, David Callecod, who has 2 decades of experience as a leader in healthcare administration. He is the president of Lafayette General Health System, which under his leadership has experienced rapid improvement. So for those of us that remember 15 years ago, 10 years ago, how the system looked and how the hospital looked, and how it has transformed not only physically in our community and beyond, but how it has improved patient satisfaction and quality outcomes while expanding the physical plant itself and the regional network and all the awards that it continues to win nationally on a regular weekly basis. But the impact of the hospital system is felt way beyond the walls of the hospital and the healthcare delivery infrastructure in terms of how the system continues to impact the community and all that it touches. So I want to thank David for his leadership and members of Lafayette General System that are here today and that collaborate with us on any number of issues on a daily basis to help improve innovation outcomes and health outcomes in the state and beyond. So with that, thank you. David Callecod.
Thank you, Ramesh. Quicker, please. Good morning, everybody. Good morning. So, Ramesh, I appreciate that introduction. And earlier, Ramesh called me doctor, but he's like 3 years premature because I'm just starting my PhD program. But I like the sound of it. It felt good. Yeah, in organizational leadership, though, so I'm not going to be treating anyone, just so everyone's clear on that. So. It is a pleasure to be here, and it's a pleasure to be a longtime sponsor of this event from the very beginning. And it's very important, certainly, as we bring in thought leaders from not only around the state but around the country to address issues that are here, but also that affect our entire country. And it's wonderful for us to have the ability to participate. Lafayette General is the health system, community-owned, not-for-profit health system that serves all of Acadiana, which is about 9 parishes in southwest Louisiana. We really take care of, as a level 2 trauma center, everything from the Atchafalaya Basin over to the Texas border and kind of midway up to Shreveport. And in that role, our 4,400 employees, 7 hospitals that we own, 2 that we help manage, and 5 others that we're clinically affiliated with. We're partnered with probably a couple thousand physicians over that area. We have 80 employed physicians of our own that form our LGMD physician group. And in that, our focus is to restore, maintain, and improve health of this entire region. And one of the focuses certainly that we have going into this year and in our management and as we grow our population health initiatives is this opioid epidemic and our ability to affect that in our region. And so I'm going to talk a little bit today about sort of what's going on nationally. I have the honor of participating as a member of the Regional Policy Board for the American Hospital Association for Region 7, and then also am the chair-elect for the Louisiana Hospital Association. Will serve as chair of that organization next year. So I'm going to talk about American Hospital Association initiatives, Louisiana Hospital Association, but more importantly, what we're doing here locally to address the situation within our health system. So for the folks here that are going to be doing the coding, I think overall my message is that while hospitals and health systems understand that this is a problem, we all know that this issue cannot be dealt with just with providers working independently and trying to change things within their practice. There has to be collaboration, there has to be coordination, not only within that system, but also amongst all physicians and all providers within the ecosystem of healthcare. And it needs to be a very coordinated response to address not only the initial prescription and prescribing of the drug, but also certainly as that drug enters a phase of abuse. I hope out of this that we come up with different ways to partner, share information, not only between healthcare providers, but also state and local health departments, also certainly law enforcement, which unfortunately has become the de facto healthcare provider for many of these folks as they end up incarcerated, and then also certainly within schools and community organizations. So in regard to the American Hospital Association, what's going on with the AHA, they have 9 priorities to deal with the opioid epidemic, and it is one of the top items in the American Hospital Association agenda this year. And so I'm going to focus in on the Lafayette General and Green items. So as we look at, one, comprehensive health insurance coverage, making sure that substance abuse is covered. Also, enforce mental health and substance abuse parity laws. And so as we look at that, making sure that there is parity. I mean, this is a condition that is no different than any other medical condition. And so it deserves to have parity in coverage for commercial contracts. Repeal of the institutions of mental disease exclusion. And so what that is the federal requirements that do not enable Medicaid to cover substance abuse with Medicaid patients. And certainly we want the ability to have that coverage because, again, a lot of these folks that end up with these issues are not able to keep employment. They don't have health insurance, and they end up in either a situation where they don't have coverage or they're on Medicaid. The CFR 42 CFR Part 2 talks about the patient information. That's very important, particularly in this environment, because right now we're not able to share information really efficiently and effectively amongst healthcare providers and other institutions that provide any type of care because of that CFR. Also improve the efficacy of the prescription drug monitoring programs. They're throughout the country, but in a lot of states they're very clunky. They're difficult to use, and so we need to make sure that we invest in these as a country so that it again does not impede healthcare providers in figuring out the information in regard to the current use of opioids by each of their patients. Going on down to number 7, encourage and fund prescriber education. I think one of the most important things that we can do as a country, and the AHA feels this as well, is that we have got to educate our providers that what they learned, certainly from the drug companies, what we thought was the truth, is not. And that this opioid crisis is a cancer that is ravaging this country. And so provider education is very important. And certainly you'll see how we're doing that within our system here in a second. So Lafayette General Health, the things we're working on, we know a number of things. One, if you're familiar with electronic medical records, it's all about reducing the number of clicks that a physician has to make and to make it as efficient as possible. And before I go on, I see a bunch of my IT folks here in the crowd and also Lafayette General folks. Hold up your hands so everyone can see all the various Lafayette General folks that we have here today. Excellent, thank you. So the IT folks know this. We're trying to reduce the number of shortcuts as we have documentation in the ER, and we want to make it a seamless process as the physicians have to go and look at the database to look at the current use of drugs with their patients. Creating policy and guidance to include pain medication contracts with all of our employed physicians. We're also working with CME for opioid management, not just within Lafayette General, but us in our statewide partnership that we have with Ochsner Health. And so we're looking at CME throughout that entire organization. And then analysis of opioid prescriptions generated. We currently have the ability to do that in-house for our employed physicians and within our system, and it's been quite interesting and really speaks to my passion that I have in regard to education. So as we look at the PMPM program across the country, you can see the blue states, they're available, and in the green states, They're not only available, but it also is state funded. So as all of us that live in Louisiana know, the state has trouble funding everything. That was a joke. Y'all been following me on the news and the radio about UHC. So our state does not pay for it, but it's available. And so we pay for that integration. Our partner is Cerner. We are a show site for Cerner. We host folks from all over the country, and actually some folks that have come in from Europe. And so we with our partnership with Cerner, we're working to implement this PMPM and the next program, which I'm going to talk about, which is NARCS Care, over the next 60 days. And so within NARCS Care, which is embedded in Cerner, it allows us, in the current workflow of the physician, to do the PMP inquiry. It matches the individual. It provides the physician with an overall, it goes out and searches the databases to look at current prescriptions for that patient, gives the patient a score that predicts their likelihood to become addicted and to have a problem of abuse with the drugs. Also, this program is going to allow us to meet all of the state and federal requirements for monitoring and auditing these processes. And so here's a snapshot of what NARCS Care looks like. And again, you can see the scoring that every patient would have. And so that 36 is on a scale of 99, predicting, using predictive analytics, the likelihood for that patient to develop addiction. And then that final number that you see on here are the current number of open scripts that the patient has. And so gives you an idea of some of the technology that we're using within Lafayette General. Also embedded in the program is education, and so we believe that it has to be readily available to the physician, to the nurse practitioner, to the nurses, to give to the patient at the time of the prescription, so they understand the risks and benefits of the prescription. In order to address this as well from an inpatient standpoint, we're looking at how to reduce diversion or theft of drugs. And so within our system, we use Omnicell, and in this Omnicell platform that we have, which again is integrated with our EMR, we are able to look at the medications ordered, the medications administered, how many milligrams were delivered, how many were actually given to the patient, and then monitor the waste of that drug so that we can very quickly identify if we have an issue with diversion. Addiction amongst healthcare professionals is a tremendous problem, and the access to it is a tremendous problem once someone has this type of addiction. So LHA is the Louisiana Hospital Association. Again, I will begin my term as chairman of LHA in July. Every chairman ends up with a project that they push for the term of their leadership, and so I'm happy to report that the opioid crisis and hospitals really being very active in trying to improve this within our state is going to be my project throughout my term. And so in July, we're going to be rolling out the effectiveness of the programs that we have at Lafayette General and the types of things that we have done to improve this within our community. I hope that I have takeaways from this event that I also can share with the Louisiana Hospital Association, so Louisiana can begin moving this metric and improving the situation within our state. I'll close by just saying I would bet, and I would ask everyone to raise their hands, but I'm not going to do that. I would bet every single person in this room has a loved one, a family member, a friend who has been affected by what I called earlier this cancer. And when it takes hold of an individual, it is absolutely brutal. And this event is important because we need to help give those patients their lives back and those families their loved ones back. And so this important work that you're doing, we appreciate you being in Lafayette. Certainly welcome to our community. Thank you very much.
David, thank you for those comments and great initiatives, not only within the hospital but in the system, but in your incoming role as LHA chairman. And I wish you every success. And thank you and congratulate you for taking on such a challenge, as a small challenge as opioid crisis, to be the legacy that you leave behind in your role as chairman. So good luck to you, and please count on the university as much as you can to support you in that effort. For those of you that may not be aware, the university is home to the nation's oldest computer science program in the country. One of the most prominent computer science programs. Our master's degree in computer science was offered back in 1962, when computer science was not even a recognized discipline. So I tell people we were geeks before Big Bang Theory made it cool to be a geek. But we have not just sat on the laurels of that accomplishment. Over the years, we've continued to invest into it. And today we are recognized by the National Science Foundation as the nation's only NSF Center of Excellence in the area of big data. And again, as I said at the very outset, we don't go into these things thinking that we know all the answers. That center is an industry-university collaboration, with industry being on the front end. Industry partners and organizational partners tell us what problems they have, what data they have that they are trying to get insights into. And we apply our intellectual capacity. And again, as I said, we don't go into thinking that we know all the answers. We build a network of university partners from across the nation and across the globe to be able to harness the collective intellectual assets of all of those folks and apply that to solve problems like what we are discussing today. So when, David, you showed your predictive analytics and the predictive score of someone being likely to be an addict or likely to get into that kind of an addiction, those are the kind of predictive analytical capabilities that our faculty, working with our doctoral students and undergraduate, graduate students, are building. So we are indeed working very hard and very diligently on bringing and building the next generation workforce that is able to rise to the challenge of addressing these kinds of opportunities that we are going to be faced with because of the challenges and the crises that we have to deal with. So thank you for those comments, and we'll slightly change the order, and we are nothing if not flexible and nimble. Dr. Cassidy is a few minutes away, so I'll next point to Dr. Rebekah and ask her to be willing to work with us in changing your speaking order, if you would. For those of you that do not know, and I would suspect that there's not any in this room, Rebekah is the Secretary of the Louisiana Department of Health, the state's largest agency with a budget of about $14 billion. Dr. Gee's oversight responsibilities include public health and other service programs for citizens in need. She is focused on behavioral health, developmental disabilities, aging and adult services, emergency preparedness, Medicare, Medicaid programs. I have gotten to know Rebekah over the past decade or so in her various roles within the agency, and now in her role as the secretary of the agency. And one of the most passionate people that I know in terms of understanding the value of the role and the mission of the Louisiana Department of Health in terms of improving public health outcomes in the state of Louisiana. I could go on to brag for a long time, but one of the things that I leave you, because I'm a researcher and a research vice president, so on a daily basis, my job is to go look around the nation to go recruit the smartest people and try and bring them to the University of Louisiana at Lafayette. And one of those designations for smart people is a recognition by the national academies, that you are a National Academies of Science or Engineering or National Academies of Medicine member. And there is not perhaps one other cabinet secretary in the country that is a member of the National Academies. And I'm very proud to introduce Secretary Gee as a member of as an elected member to the National Academy of Medicine, and perhaps the only one that I know. I Googled, folks, and I searched up and down, and I couldn't find another cabinet secretary. So that's my story, I'm sticking to it.
All right.
Dr. Rebekah Gee.
Thank you, Ramesh. Thanks. So, good morning, everyone. We're sitting in a room with some giants. I first wanted to thank Ramesh and Henry and the leadership here at UL. I am the sister-in-law to two proud graduates of this esteemed institution, and we're also here with Bruce Greenstein, my former boss,
who's helped walk me through what I call, I was told that when I took this job I had to have nerves like sewer pipes, which is very true. Bruce has certainly experienced it, I experienced it, but those of us, I'm very proud to have worked with him. He did a great job leading the health department and helped us reduce infant mortality by 25% due to his leadership. Thank you to Dr. Tina Stefanski. I have some wonderful folks from my office here. She's our regional public health director, really stands on the front lines in the event of hurricanes, any flooding, Zika virus outbreak. Our public health infrastructure saves lives, and we have infrastructure in each region, but Dr. Tina, I have to say, is the most popular one. Don't put that in the, she's incredible. Every day I get comments about her work. Kelly and Pete and Carrie are here. Please raise your hands. From my office, tremendous folks. The best thing about my job is the incredible people I get to work with. So, as Ramesh said, I have the opportunity to lead a health department that crosses a lot of boundaries. And we're responsible for the evacuation of medical facilities in light of weather events. We are responsible for inspection of your food. Oyster beds get inspected by us. We also do maternal and child health. We also run the Medicaid program, which, as you may know, has 1.7 million people in this state. And that's a great thing. It's because it's a poor state. We have, we're number 3 in the country, highest number of people who live below 200% of poverty. So that fact means that we have a lot of folks who are struggling to pay their bills, make ends meet every month, and simply could not, prior to the Medicaid expansion, afford to get health care. I'm going to talk about how important that is in a minute. How many of you know someone who has addiction? Okay, so we've all experienced this, and the opioid crisis is a symptom, I would argue. This is the symptom of a broader issue in our society. One, of course, is genetic, and the genetic component of addiction is very important. And the other, I would argue, is the social isolation, loneliness, pain that people feel that they treat, whether it's opioids or alcohol. You know, people have their drugs of choice, but this is a problem of the moment, I think partly because we've lost touch with each other. And I know we got a lot of techie people here, but I worry as a mother of 5 children, and I see my teenagers on their iPhones, and I wonder how they'll be socially when they're my age. Will they feel isolated? How do we deal with this issue of making people feel connected and supported? So when I think about the opioid epidemic, I look at it as a 3-legged stool. And the most important stool in terms of our approach to it is what I call health equity. And health equity means that everyone, regardless of their skin color, regardless of their income, has access to health care. Health care, to put it simply, as a practicing physician, and welcome, Senator Cassidy, as a practicing physician and someone who unfortunately has been a patient a lot more than I had planned, is a human right. Healthcare is a human right. This is the richest country on this planet. There is absolutely no excuse not to be providing healthcare to every citizen of this country. And healthcare doesn't mean an emergency room visit. Healthcare means you can have a mammogram if you need one. Healthcare means you can have a colonoscopy if you need one. Healthcare means you can go to a primary care. We're having lots of conversations, frankly, that are very punitive in nature about let's punish people and take them off if they can't do. Well, you know what? A lot of people don't work because they're sick. A lot of people don't work because they have addiction that needs to be treated. And just kicking them off of their healthcare is not going to fix the problem. It's going to make it worse, and they're going to show back right up in that emergency room they were getting care in before. So I think it's unfortunate. I think the conversations we should have at a national level should be about investing in our future, investing in our economy, and investing in our people. And that means making people healthy. And that ought to be a priority. And that's what we have done when we think about health equity. Governor Edwards and I have presided over what was the biggest change in a generation in this state. When he and I started, 1 in 4 people, 1 in 4, did not have health insurance. And you can say, well, that doesn't, maybe doesn't matter because you could go to an ER, but that's not enough. Okay, so now in this state, fewer than 1 in 10 people lack health insurance. And as a practicing doc, I know that matters. I see patients in New Orleans. And a lot of folks in New Orleans are musicians. That's what people love about Louisiana. Frankly, here in Lafayette, New Orleans has good food, Lafayette has good food. We could go toe to toe. The food here is incredible. The music here is incredible. A lot of the economy of this area is around people who want to come here to enjoy that, right? But that's not necessarily regular 9 to 5 everyday work. A lot of people have gigs. A lot of people work in hotels. A lot of people's employers skimp on wages. And as you know, we're the biggest gap between men and women in the nation. $11 billion difference between what women make and men make toe-to-toe, job to job, okay? So there's a lot of issues why people are poor, okay, and why they don't have access to care. But that is part of the fact that we are poor. We have an economy that's based on some industries that aren't necessarily predictable. So this has been a major change to have access to care. Most of the people are working who have Medicaid. They're able to be more productive. And what, just a quick plug and then I'll get into opioids, what has been announced this week, which is incredible, is because of the Medicaid expansion, which was a $47 million investment on the part of the state. We had 3.85, and this is a Jim Richardson from LSU, a well-respected economist on both sides of the aisle, $3.85 billion of economic activity, 19,195 jobs. So match that. All right, what has happened in a generation in this state that's brought 19,000 new jobs? So it's been incredible. Not only are people getting mammograms, 35,000 of them. My mom died of breast cancer. 320 women have been diagnosed. You could say, well, maybe the access isn't there. Well, it's not what it needs to be, but tell those 320 women that breast cancer diagnosis doesn't matter to them. It does. 22,000 colonoscopies. 18,000 visits for substance abuse. Those are 18,000 people who might be dead, right? Because when you're addicted to opioids, what happens? You stop breathing when you take too much. And if you don't have access to health care, you may never start breathing again. So these are really important numbers, and they matter, and they create a seed of health equity. Because we can talk all we want about changing the system and improving things, but if people don't have access to health care, if they have nowhere to turn when they have an addiction, other than an emergency room, then we're really giving lip service to this problem, in my view. Because you have to deal with this, of course, health equity is so much broader than healthcare, but healthcare is an important piece of this. So providing a seed of health equity is important. So what are the other legs of this stool? One is preventing addiction. We know that 80% of people who do heroin started with an opioid prescription. And, this was a problem, as we talked earlier about addiction being genetic. The opioids are a symptom. It's a kind of addiction. There are many ways people feed addiction. But this problem was created by pharmaceutical companies, right? And I remember being a daughter of someone dying of cancer in the early 90s. There was a big bill of malarkey sold to doctors and patients throughout the country, and it was this: everyone, pain is a vital sign, everyone ought to be treated, and by the way, they ought to be treated with our drug, OxyContin, oxycodone, and so on. They made billions, okay? And they suppressed the data that showed that addiction was occurring as a result of these prescriptions. And many of us didn't know, right? We were, as practicing doctors, as a med student, I thought, well, everyone should, pain is terrible. We don't want anyone to have pain. Here we have a treatment, let's give it to people. What's wrong with that, right? We didn't know, though. And there is a big problem now because of, similar to the tobacco industry, a lot of lies that were told to providers and the American public about the safety of these drugs. Okay, so as a result, we were giving them to many, many people who didn't need them. So as a practicing OB, I've delivered over 500 babies. We would just give 30 or 40 pain pills to every woman, regardless of whether she needed them. That's what I did in residency. We had scripts: Motrin, Colace for constipation, and opioids, right? We just did that for everyone. We didn't know. Okay, so we created this incredible problem. But the good news is that it's easy to address. And in the 2017 legislative session, our medical society, which I'm very proud of, usually the docs are the toughest people you have to deal with, right? Because we think we know everything, okay? So usually docs don't want to be told or required to do anything, but they wrote a bill saying everyone in this state, dentists, nurse practitioner, doctor, you prescribe opioids, you must do continuing medical education and understand what was not taught to us, that opioids kill, and that we need to think really hard before prescribing them and think about how many we're prescribing. So kudos to our medical society. Also, we pass limits. So the limit's 7 days, and a lot of people, the evidence at the CDC level, addiction medicine, opioids don't work for long-term pain. And unfortunately, we need better treatments. My dad can barely walk because every time he steps, the nerves in his back give him piercing pain. I wish there was something better for him. We need more research, but the bottom line is it's not opioids. Opioids are not the answer. Study in JAMA came out last month. They don't work any better than Motrin, Advil, and so on. So if they don't work better, why are we giving you something that could kill you? We shouldn't be for long-term pain, and we've changed that. So with the Medicaid expansion, there have been some allegations that, we've made all this problem worse. No, we haven't. You know what's happened? With the Medicaid expansion, people have access to care, and with these new limits in place, we have reduced by 10 million pills. The scary number is 10 million pills. Do you know what percentage of overall prescriptions that is? That's only 2%. We have more prescriptions than every man, woman, and child who live in this state. But we have been able to reduce dramatically. We've been able to educate on the labor floor where I used to deliver babies. We no longer give a script to every woman leaving. So that's a big change. That's the pipeline. That's one leg of the stool. How many people are addicted? The second is treatment. So we are one of 5 states to have been given an 1115 waiver for substance use residential treatment, meaning that if someone needs to be in a facility, they can stay there to be treated for their addiction. So that's very exciting. That's not everything we need, but that's something. We're also doing medication-assisted treatment. Also in my budget, and it depends, I know David Callecod, future doctor, thanks, Ramesh, has been a great proponent of what the budget cuts would do to this part of the state. So I'm hoping we'll still have money. It's only going to cost $2 million to cover methadone for Medicaid, which is an important thing. We need to have tools in our armamentarium. Addiction is a lifelong disease, just like diabetes, just like hypertension. How many people who have diabetes think, I'm going to get off of my diabetes meds next year, and feel that they fail when they don't? I would argue they don't. The people understand that diabetes is a chronic disease for most, similar to addiction. Many people who are addicted to opioids will need lifelong treatment, and that's not a failure. That's a fact. So we need to provide alternatives and as many options as possible. So methadone, Suboxone, these are the kind of things, and treatment therapies, and as I mentioned, 18,000 people have had access to substance abuse treatment through the Medicaid expansion. So that's really exciting. So what's the final leg of our stool? Is saving lives. Okay, so people who are already addicted, we've got to make sure they don't die, right? High priority. So 2 years ago, I signed a standing order. In fact, I went into CVS last week and I was getting a prescription. This lady goes, "Is your name on that standing order, Dr. Gee?" I said, "Yeah." So anyway, so if you go to any pharmacy in the state, Dr. Gee's written you a prescription, you can get Narcan. Now, the unfortunate thing is it's very expensive. That's another issue we need to deal with at the national level, is the prices of drugs. But it's available to you. And we've distributed 12,000 doses to first responders, EMS, state troopers, all over the state to try to combat and use a data-driven approach. And I know that Dr. Gershanik will be here later to talk about our dashboard, but we need to be data-driven in our approach to saving lives. So that's a big focus, and I hope you'll help us with today, is thinking about making sure that we target areas that are high risk. We ought to know who are the individuals who are at risk for overdose and be able to get them treatment to save their lives. So that's our three-legged stool, supported by health equity. I'm really excited to be here with you today. I want to learn with you and from you. And I hope we have a really productive conversation. Thanks. And I think.
Thank you, Rebekah. I truly appreciate those comments, and your comments particularly about healthcare being a human right and data-driven approaches to saving lives do indeed resonate with all of us. So thank you for your comments and your continued investment into these efforts. Finally, it is my honor to recognize the last speaker on this morning's panel before the break, and that's Senator Bill Cassidy, who's our senior senator from Louisiana, who serves on health education, labor pensions, energy and natural resources committees, finance, Veterans Affairs, and joint economic committees. And in all the spare time, and before getting into that role, he co-founded the Greater Baton Rouge Community Clinic. He is a person who has been on the front lines of delivering care to those that are among the neediest in our communities, and a clinic providing free dental and health care to the working uninsured. But I'll tell you, as a researcher and as a research vice president, he's a researcher's dream because he is one who understands the value of research and innovation that we do in our universities and our laboratories across the state and across the country, and how they really need to transition into the marketplace in order to help save lives and impact population health in one of the most meaningful ways. I think it was for the first time in the history of the state of Louisiana that I saw the three national leaders for the National Science Foundation, the National Institutes of Health, and FDA all being convened at a meeting about 2 years ago for the first time in my history of 25 years of being a Louisianian, that these three leaders were in Louisiana talking about what we do in Louisiana and what research is coming out of our universities and how our federal agencies need to partner with us in helping improve population health in a state that so desperately, obviously, needs that improvement in healthcare. So thank you, Senator, for leading from the front, and with that, over to you, sir.
Hey, thank you all for having me, Ramesh. Thank you for that nice introduction. And my hope is that first, what is my role here? My role is hopefully to give you some of the information that you can use to find solutions that will help do something about the opioid epidemic. And when I first thought I'm coming to the Cajun Code Fest, I had to start kind of imagining just the potential that is here. Now, I'm a physician. You may know that. I'm a gastroenterologist. My standard joke is that gastroenterology prepared me very well for politics. If you're over 50, you get the joke. If you're under 50, just you wait. On the other hand, it does help because it gives me a perspective of mental health and the related issue of opioid addiction. In 2016, I worked with Senator Chris Murphy of Connecticut on the mental health bill of 2016. And I noted if I went to an affluent neighborhood in Louisiana or if I went to one which was less well off. And I started speaking about how mental health issues, serious mental illness, touches us all. In my case, it's my family. In your case, it might be as well, but it's at least a close friend, somebody you went to high school with, who you noted at the time there was something different about her, but it was only later that you learned that her marriage broke up, her kids were in foster, she was perhaps homeless, and you now recognize the role as serious mental illness. And wherever I was, whether it was the Martin Luther King Center in the Lower Ninth or a well-off suburb in Lafayette, Louisiana, people would nod their head yes. It cuts across. Now, unfortunately, I can also say that's true of opioids. Each of us has been touched by someone we love in our family or among those whom we know who have been touched by opioids. But unlike serious mental illness, it is not something which will occur and we recognize it 20 years later. It's something which we see now. We see it at the obituary. We see it at the funeral we attend. We see it at the tears of someone we know who just lost their child, their grandchild, their spouse, their partner, their brother, their sister. And just as I said, it cuts across. No matter what setting to which you speak to this, there is a head that nods yes. There is an eye that tears. So our challenge is, what can we do about it? My hope, and I'm flipping down to my notes, give me just a second, is that we can use this sort of forum to find a solution that makes what I just described less likely to occur. Now let me give you a little bit of a framework of the problem and where big data or some other intervention can make a difference. We have drugs being written by two types of physicians that are a problem. One is the pill mill, the physician that rolls between state to state to state. You walk into his practice, you give him $500 for a 5-minute physical, and you walk out with a handful of prescriptions. That's one problem. The other is what Dr. Gee just referred to. It is the well-meaning physician who doesn't want you to hurt. And statistically, we know that if you have two ER physicians working in the same emergency room, seeing the same type of patient, say a sprained ankle, some of them will write a 30-day supply, and the other will write a 3-day supply of opioids. Now, statistically, there's going to be somebody with a genetic predisposition to addiction that if she gets that 30-day supply, she will end up her 30 days as an addict. Not because she intended to, and not because the doctor was not well-meaning. Indeed, you could suggest he was too well-meaning, but the point being that the overprescription is what caused the problem. Now, everything I've said so far is replete with opportunity for big data. I see Ramesh over there nodding and said yes. Oh yeah, because we have, and Dr. Gee referred to it. If you talk about the pill mill doctor, we have something in every state, or almost every state, the prescription drug monitoring program, where every physician writes down his or her unique identifier, so that if I give you, ma'am, a prescription for opioids or Valium, you take it and you fill it, and they log in that Bill Cassidy, your gastroenterologist, wrote you for this medicine. And a pharmacist enters it, and other physicians can then look at it. Well, wait a second. This patient has picked up prescriptions from 10 other doctors. That's not right. Or law enforcement. It can be referred to law enforcement. And law enforcement can say, here's a doctor writing for lots of prescriptions. He's not a cancer doctor. She's not a pain doctor. It's a family practitioner who, wait, let's look at this, was previously in Georgia, Alabama, Mississippi, always one step ahead of the law. Now that's the power of that. Hats off to our medical society. We're one of the few states that proactively shares that with law enforcement. Saying, hey, law enforcement, we've identified a problem, need to do something about it, and law enforcement sweeps in. But, by the way, DEA has not been doing this. DEA has been so focused on illegal drugs coming across the border that they've not focused upon the legal prescriptions that have been written here inappropriately. That has changed. Jeff Sessions, who is the Attorney General, of course, about 3 months ago announced that they were to begin doing this, and they would begin using this sort of a database. But let me tell you the limitations of that data. Imagine you're in Shreveport. You can go to the VA, and you can go to a private doctor, and you can go to Arkansas and Texas all within one day. Potentially picking up prescriptions that would not be detected because Louisiana doctors may not know what the Arkansas doctor is doing, what the Texas doctor is doing, what the VA physician is doing. The VA is supposed to integrate their data. In about 17 states, I'm told they've not yet integrated their prescription data into the PDMP. We have an opportunity for big data. We have the opportunity for someone who knows how to figure out that system to do it better. Some already have, but we've not yet adopted that. One more problem. If I get my 5 prescriptions from the pill mill and I go and pay cash, that PDMP may not register that data for a week. And by that time, I've gotten it all. Okay? Now that's a problem. And we have to work through that. But let's just not stop there. We've been talking about the legal supply. Let's talk about data applied to the illegal. When I ran for politics 10 years ago, my hair was the color of David's. Now I tell my children it's platinum blonde. But in 10 years, it's this sort of thing that has given me gray hair. Actually, it's teenage daughters that have given me gray hair, but aside from the teenage daughters. Mexican drug cartels reportedly generate $110 billion a year from illegal drug trade, which they transfer to Mexico. 110 billion with a B. The federal government manages to seize 7 billion of that. We're getting less than 5% of all the dollars generated by illegal drugs. How do they move the money south? Trade-based money laundering is one example, where somebody has a good in Mexico. The manifest says that it's a cell phone. Now, it could be a smartphone worth $1,000, or it could be a flip phone, or it could be no phone at all. It is a double manifest. And they use that arbitrage, that kind of, okay, this is what we tell you we're shipping, so therefore we're going to spend that much money. In reality, they just shipped $1 billion down for $500 worth of material, or maybe fictitious material. We need to do a better job tracking trade, because that's neither supply nor demand, that's financing. And if you can take care of the financing, we would stop the illegal drugs moving here, that as Dr. Gee speaks of the decrease in legal, that void is being filled with illegal. And that's all data. That's all data. How do we get federal agencies and companies to better cooperate and better analyze so that we know that data coming, we know those goods coming across are real and they've been valued appropriately, and the money moving south, we've been able to track it, and so we know it's not laundered money, rather it's appropriately done. One more kind of data-oriented solution I wish to mention. Dr. Gee spoke about treatment programs. So we've talked about the supply, and we've talked about the financing. How do we decrease demand? Well, you decrease demand by treating people and keeping them in recovery. But when I have a committee, and there's folks here from the treatment community, and I say there's some of you, treatment facilities in general, that do fantastic work, and that somebody comes through that treatment facility and she is most likely to stay clean, or much more likely to stay clean. And there's some that are just mills, that they come through, they get their check, but there is a high, I see heads nodding over here. There is just a constant sort of, you're right back in, someone's pocketing a check, but it's a rip-off of the taxpayer, and it's no good done for the individual who's going through the treatment program. We need to analyze that. We need to use our data to understand, wait a second, you go through here, and you're less likely to be seen within a year for a opioid-related event in an emergency room, or you've been seen here, and as best we can tell, you're being readmitted, you're showing up in the emergency room, you're needing Narcan, boom, 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 boom. So on the treatment side, the decrease the demand side, that is another effort that we have to come to. There's many other issues as well. We have an initiative that we are rolling out, and we call it the Safer Families, Healthier Communities. And we attempt to touch each one of these facets. I'll mention some because, Lauren, raise your hand. Lauren Casanova works for me. She works for you. She's employed by your federal tax dollar to be the representative of this Senate office that I have the honor to hold temporarily. And if you need something, grab her card. I think it has her cell phone. She's not married. Call her up anytime. She's available, she loves to hear from you even if it's at 3 in the morning. She's in Crowley. She's a local girl. She'll do great. So that said, some of the stuff that we've been able to do that I just want to mention. We passed the Comprehensive Addiction Recovery Act, the Cures Act, which puts the Emergency Medications Act. We put those all into law, and last month appropriated about $3.6 billion more than the billions appropriated in those dollars to fight the crisis. We've asked the General Accounting Office to do a review of the Foreign Narcotics Kingpin Designation Act, the folks running the cartels, how well is it working to capture them and to break up their activity. And we're also looking at federal government efforts, the effectiveness to stop gang activity and gang violence. We've been pushing the DEA to use big data in order to more effectively track which physicians are prescribing drugs in a way which is inappropriate. We've asked the U.S. Department of Education to come up with an education program to bring into our school systems so that when a child begins in the first grade, she or he throughout his years is learning the danger of opioids, just as I once learned the danger of smoking. That is our new smoking. We've introduced legislation again to stop pill mills. We've introduced legislation to increase the penalties for fentanyl distribution. Another $1 billion for prevention, enforcement, treatment, and recovery programs, trying to secure the border to stop the flow of illicit drugs and money laundering, and again, aggregating big data in big time. But that said, all this is just making resources available to you. None of this will be successful without you. I thank you for being here. I thank the organizers of the conference. If there's anything we can do to help you serve those folks so that 5 years from now we don't need to have this conference because the issue of opioids has been addressed, that may be too much to hope for, but it's a great hope to have, and many people's lives depend upon us as much as possible fulfilling that hope. Thank you very much.
Thank you, Senator. And that phone number is 337. Thank you, Senator, for those really outstanding comments. And every time I meet you, I write down more notes, I take down more notes. So you continue to school me, and I don't have to worry about tops. So that's a great benefit as well. But the point that you mentioned about bringing this to schools and engaging students is absolutely why today at noon we have the Cajun Code Fest, the hackathon portion that will begin, and of the 150 plus students, participants in the hackathon, we have about 70 or 80 students, and there's the Lafayette Parish School System, high schoolers and middle schoolers. So if you're in this room as a student participant, would you please stand up and be recognized? Because you're indeed our hope to solve this problem. Because hopefully, as Senator Cassidy said, we'll be able to solve this problem in the next 4 to 5 years. But if not, you're on the front lines. And especially when we come together in organizations to solve problems of any import, we ask ourselves the question, okay, whose problem is this to solve? Who owns this problem? Who should be taking the lead on solving a problem like this? But when opioid epidemic kills more children and young Americans under 50 than any other disease, it becomes a child and family services and social services problem. When 1 kilogram of smuggled carfentanil makes its way from China to Canada, roughly an amount that's enough to wipe off the entire population of Canada, we guess it becomes a law enforcement and criminal justice problem. When Kermit, a small town in West Virginia with a population of 400 people, has 3.5 million opioids dumped on it by pharmaceutical companies, as Rebekah said, it becomes a pharmacy supply chain and distribution surveillance problem. But when 7 Americans die every hour, it becomes all of our problem. It becomes an American problem that will require American ingenuity and our ability to collaborate, communicate, and innovate. And that's my hope for today and beyond. And that's my call to each and every one of you. So at this time, we have a break coming up. We are ahead of schedule, though we started 15 minutes behind. So thank you to our speakers in the morning for making that possible. So after the break, you will come back at 10:30 when my good friend Bruce Greenstein will moderate the panel, and we'll have great conversations, not only in that panel, but in the afternoon, where we have a round table with participants who truly are on the ground, on the front lines, in the fringes, dealing with this problem every single day. So again, as we said, it will require conversations, it will require us going into these not knowing that we know all the answers, but with a willingness to work together and to collaborate, coordinate. So thank you for being here. Thank you for your commitment to this cause. And with that, we call a break. Thank you.